Hello, dear colleagues, friends, all those who are here in this room and those who are online with us from different parts of the world. We have more than 1,000 people registered for this event outside this room. So people are listening and people are interested what we think in globally. So I'm Dr. Akhtar Hussain. I'm the president of International Diabetes Federation. It is my pleasure and an honor to welcome you all for this very important event. This will be, so today we're going to have some statements in the beginning from some of our ministers of health from several member states, followed by a discussion panel around the topic of accessibility of diabetes care for people with diabetes, particularly in the low and middle income countries. I would also like to extend my thanks to the American Diabetes Association for their support to this event, to all organizations who have supported IDF to improve access to diabetes care. Unfortunately, the president of the American Diabetes Association, that he was supposed to attend here, who could not attend because of some kind of family emergencies. And we all understand that families are important. To start with, I would like to present one video by Dr. Tedros, the WHO Director General, the video message for all of us.
Your Excellencies, Professor Firas Abiad, Dr. John Manguiro, Mr. Zahid Malik, and Mr. Abdul Qadir Patel, Professor Akhtar Hussain, dear colleagues and friends. In the time it takes me to make these comments, diabetes will kill 6 people somewhere in the world, 3 every minute, more than 4,000 every day, and 1.5 million every year. Diabetes is a contributing cause in the deaths of millions more. 422 million people are living with diabetes, and in much of the world, they face significant barriers accessing the medicines they need. A recent WHO report showed that supply chain disruptions during the COVID-19 pandemic have made it even more difficult. In 2021, WHO launched the Global Diabetes Compact, which aims to reduce the risk of diabetes and improve its treatment and care worldwide. The same year, we published a comprehensive report on making insulin access universal. Since then, we have pre-qualified the first human insulin, pushed for new commitments from industry, and supported member states to procure insulins and glucometers. We're thankful to all of you for your commitment to advancing diabetes prevention and control around the world, and especially to the International Diabetes Federation for your long-term partnership. Together, we're working to support all people living with diabetes to access essential, affordable, and quality care. I thank you.
Now it is my distinct honor to invite Honorable Dr. Firas Abiad, Minister of Public Health from Lebanon, on the stage. I would like to invite Dr. Khan, the Director General of Health, from Minister of Pakistan, to be present in this event and invite you on the stage. It is also my pleasure and an honor to invite my long-term friend, the Honorable Dr. John Manguiro, Deputy Minister of Health, for childcare from Zimbabwe. I will also invite you on the stage. Now, I will ask that every person that is here should say, in short, I'm sorry, my apologies, the time is limited to 5 minutes maximum, to say that what you are doing in order to secure the accessibility of diabetes care to the people with diabetes. So should I start from our Honorable Minister from Lebanon? Because his country is also facing a kind of problem that we know that the refugees problem, that people are in exile. So it would be very much interesting to hear that what you are doing in your country.
So thank you, Professor Akhtar, for the invitation. And indeed, Lebanon has been facing a severe economic and political crisis, and that has led to shortages in essential medications. Unfortunately, diabetes care and insulin were equally affected, and access to chronic medications and insulin has also been a problem for some of our patients, especially coming from the most vulnerable proportion of society. So the situation is particularly dire for those who require insulin for survival, such as individuals with type 1 diabetes. And some patients have resorted to rationing their insulin or seeking alternative, potentially unsafe sources of insulin. The Lebanese government, along with international organizations and NGOs, has been working to address the issue of insulin shortages. Efforts have been made to secure the importation of insulin and other essential medications through collaboration with pharmaceutical companies and foreign aid organizations. However, the challenges posed by the economic crisis and the ongoing political situation continue to hinder these efforts. In response to the shortages, healthcare providers have been working to optimize diabetes management by exploring alternative treatment options and adjusting therapy plans and emphasizing the importance of lifestyle modifications. Probably this is one of the silver lining for the clouds we're passing through, is that it has allowed us to shift a bit the focus from focusing on innovative medications, expensive medications for diabetes care, and start talking also about things related to prevention, lifestyle changes, focus more on patient educations, things that can help a bit as we are trying to solve the issue of access to medications. We also have a lot of diabetes associations and patient support groups that provide information, resources, and assistance in navigating the challenges to get access to medications and insulin. We also recently have launched a collaboration with the World Diabetes Foundation through an effort in our primary healthcare centers. And this program focuses on capacity building, healthcare system strengthening, and patient education. It's worth mentioning that Lebanon hosts more than 1.5 million refugees, the equivalence of one for every 3 Lebanese. And we implement an inclusive health policy that ensures refugees have the same access to primary healthcare services, including free medications and other programs similar to our citizens. Finally, despite all the challenges, the Ministry of Public Health realizes that within the crisis lies an opportunity. Our national health strategy, launched 3 months ago, aims at pivoting the healthcare system towards prevention and primary care, and the aim is to build a more accessible, equitable, and affordable system based on comprehensive and integrated care. And we're confident that with our partners, led by WHO, we will be able to achieve this goal. Thank you.
Thank you. And now I will invite Dr. Khan, instead of Honorable Minister, Mr. Patel, to talk about the situation in Pakistan.
Excellencies, the ministers, respected Professor Akhtar, it gives me immense pleasure to address such an august gathering over here. I'm grateful for the opportunity to contribute to the dialogue on the diabetes prevention and management. I would like this opportunity to express my deepest gratitude to our esteemed partners, including IDF, WHO, World Diabetes Foundation, and National Association of Diabetes Education of Pakistan, and all the collaborating organizations who have tirelessly worked toward addressing diabetes in Pakistan. Your unwavering support and dedication have been instrumental in driving these initiatives and making a positive impact on the lives of millions of people. The latest figure from IDF shows that about 33 million Pakistanis are diabetes, and almost similar number are in the pre-diabetes stage. These findings are based on the second diabetes prevalence survey done by the Ministry of Health, along with the collaboration of Pakistan Health Research Council, the Diabetes Association of Pakistan, and WHA Institute of Diabetology and Endocrinology, Pakistan. The fifth National Action Plan for the non-communicable disease and mental health comprehensively focus on reducing the preventable burden of mortality, morbidity, and disability caused by these disorders, aligning the global non-communicable disease action plan 2013-30. To address the high number of diabetes cases, the Pakistan Diabetes Leadership Forum was organized by the Ministry of Health in collaboration with IDF, WHO, WDF, and DEEP, and other relevant stakeholders. The four keynotes of Pakistan Diabetes Leadership Forum PLDF for capacity building, diabetes care program at national level, primary prevention and awareness, policy planning and advocacy. National guidelines have been developed for self-monitoring of blood glucose, bright, and for the optimal management of diabetes, including referral from primary to tertiary healthcare level. Various services and programs have been developed for diabetes food care, resulting in 50% of reduction in the amputation rate throughout preventing strategies. To simplify access, mass screening, the rapid score risk assessment of Pakistani individuals for diabetes has been developed. Pakistan have launched a nationwide, comprehensive and culturally acceptable Pakistan Diabetes Preventive Program. The program will utilize modern telecommunication method for a cost-effective and widespread campaign. The Diabetes Registry of Pakistan has been established to assess the extent of the national diabetes burden. These efforts are recognized and appreciated by WHO and IDF. To conclude, addressing the growing burden of diabetes in Pakistan requires a comprehensive and collaborative approach. The initiative and program discussed today, implemented through the partnership of government bodies, healthcare organizations, and international stakeholders, reflect a strong commitment to combating this disease. The progress made in capacity building, policy planning, advocacy, and providing access to essential medicine and care services is commendable. However, there is still much work to be done. Let us continue to join hands, raise awareness, and allocate resources to strengthen our efforts in preventing and managing diabetes. Together, we can create a healthier future for all Pakistan and the world. Thank you so much, sir.
Now I invite my friend, Honorable Dr. John Mangueiro, to say the situation in Zimbabwe and also the situation in Africa.
Thank you, Prof. Honorable Ministers, thank you very much. Yes, diabetes, as we know it, is a disease, say, in Africa and even in Zimbabwe, mostly in Africa. It's a disease that people still believe is a myth, and that it's mainly caused by other things other than what it is. So the most important thing, Prof, is that awareness in Africa is something that needs to be pushed before now. Diabetics in Africa used to believe it's caused by the, say, ancestral spirits, bad omen for something bad they've done. So for people living with diabetes to be served, we need more people to be aware that diabetes is real. The diabetes that we more commonly talk about, we are talking of insulin, but we remember the majority of diabetics in Africa, which is going up, type 2 as well, is there. We need as a continent, and in Zimbabwe in particular, we are advocating that insulin and diabetes medication be provided for free for people living with diabetes. Because as you saw, people living with diabetes have difficulties accessing medication, and knowledge is not there. The people living with diabetes need assistance from healthcare givers who in most cases are not well educated and are far from what is required for them to be able to help people living with diabetes. So education for healthcare givers is another thing that we need to push for. In Zimbabwe, we live in an area called SADC. That's the southern part of Africa. We are over 300 million people. So there is already cross-border linkage. Just like we are doing now, we are going to have a one SADC visa. And in a meeting in Zambia, we were saying, when we budget for our people living with diabetes, shouldn't be only for Zimbabweans, because there's lots of cross-border movement. So we definitely are moving towards a group or the whole of Africa. Fortunately, my president, the Zimbabwean president, Dr. E.D. Mnangagwa, is taking personal lead in the movement towards making sure that diabetics are well looked after. Two, that education in terms of diabetes and its complications are well looked after. To me, or to us as a Minister of Health, we found the president's attitude towards diabetes being very positive. And in his personal capacity, so that we can fight diabetes as Africa, he has vowed to be able to take the diabetes case to SADC, Southern Africa, and to the AU, African Union itself, so that the continent will be able to look after itself in terms of insulin provision. Most of our insulin, for now, is imported. As a continent, and in Zimbabwe in particular, we're in the process of making sure that we capacitate ourselves in making sure we manufacture the insulin locally, which we have done successfully. So as a country, we are moving very fast because we know, I always say so, to my colleagues and to people living with diabetes, that diabetes is medicine. Tell me which organ of the human body is not affected by diabetes. So if we realize this, we know the economy of any country can be disturbed a lot, because diabetes is a disease that can affect eyes, teeth, your lungs, your gut, your skin, your bones, your sexuality, your fertility. So we definitely need to look at diabetes, not in figures, but holistically. And fortunately, my president has said he's getting this diabetes awareness and provision of medicines a priority for the country and for Africa, which means awareness and provision is the way to go. I thank you.
Thank you, Dr. John. And this is true that I would like to very much mention that recently I have visited Zimbabwe and I met the president. We have signed an MOU, a memorandum between the IDF and the Zimbabwean government, all the points that he has raised, and to raise the issue of diabetes in the African Union. So thank you for your personal interest, and also your, please convey our thanks, not only from me, on behalf of all the people interested in diabetes, to your president for such kind act for his people and also people for the people in Africa with diabetes. I can open this, we can have very few. If you have any kind of burning questions, we can take probably 2-3 questions from the hall. If you have any to these ministers, the honorable ministers are here. So if you would like to raise 2 or 1, 2, 3, is there any burning questions that you would like to raise? Yes, please. Yeah, but he's coming. He's coming.
Thanks for the 3 informative statements. I would like to ask a question about the cost, for example, what's the cost of production of insulin in a country, and what's, for example, whether the government can reimburse cost of other medications other than insulin in the pipelines?
Anyone would like to answer? But I'm going to show some slides on this particular issue that you have raised. And yes, governments can do, but I think that international bodies can also do a lot more than what we are doing at the moment. So we will raise this issue. But if you but yes.
I think that the question, if we could reverse it, especially after COVID, I think COVID has taught us, or we've seen the disruption in logistics that has occurred. And in a large aspect, I think that some of the shortages in vaccines or medications, or the inequality in access to these essential medications was not related to the absence or presence of money. It was because of the absence or presence of opportunity. I think that this is a very important theme, that if we want equitable access to those essential medications, local capacities have to be built, because the cost of inaction, in my opinion, is much higher than the cost of action.
Please.
Actually, the accessibility in the far-flung area is a big issue, and affordability. If the accessibility, it is the responsibility of the state, and the affordability is the responsibility of the state to reduce the test or cost or the drug cost. But here I will appreciate the IDF and the civil society organization like the Pakistan Diabetes Association, who has worked with us, and we went home to home. And the cost was also reduced because there was no benefit or anything which was asked by even the companies or the people. So the treatment was also, when we detected the cases, the treatment was cheaper for those people, and also the availability of the test. So it depends on the availability and affordability of the population, and this is the state responsibility to do this.
Yeah. Yes, local production, for instance, in Africa, I know we import over 159 billion US dollar equivalent of medicines from outside Africa. And of that, only 5 billion is local manufacturing. So we have to reverse that without a doubt. We'll be able to keep our monies locally, and we will be able to make accessibility to our people much cheaper. And this will be translated the world over. So time has come, COVID has taught us, and we have learned, and we realized that it's time we looked into ourselves and depend on ourselves than to wait for outside help or outside supplies. I thank you.
Thank you. And I have one question that is coming online. That someone is asking from Pakistan. He's saying that the recent studies have shown that you have the highest prevalence of diabetes in Pakistan in the whole region, given about 30% prevalence rate. And possibly it is also true that because you have a national survey, most of the countries do not have a national survey. So most of the countries have simply pocket surveys, so therefore they do not know. But they're asking, is this alarming? And if it is so, what action you will prioritize?
Actually, in Pakistan, there is one thing more which is positive to a certain extent, also have some negative impacts, and that is the health system is devolved to the provinces. So now the provinces have all their authority to prioritize their disease response and for the prevention of non-communicable diseases. So the federal ministry where I sit, our role is to provide certain instrument or guidelines or national policy-related document to the provinces. We seek support from your good self. We seek support from the international other organizations like American Diabetes Association, and provide the provinces an opportunity for making certain local level policies for accessibility of the diabetes treatment, and for to reduce the burden on the rural population of Pakistan. So we are doing that measures in Pakistan.
Thank you very much. So,
about Pakistanis is talking about provinces. I think the most important thing, Honorable Minister, also is that we need now to take diabetes as a multi-sectorial disease where everyone is involved, rather than leave it to the Ministry of Health alone. Ministry of Education, mines, roads. I was telling somebody, we can have carnage because someone has gone into hypoglycemia. What are we doing about those with diabetics who are driving? Shall they be allowed to drive trains? Are they allowed to drive huge buses? So it's a multi-sectorial approach, Prof, that we need to advocate for, so that people living with diabetes are not only a responsibility of the Ministry of Health, but everyone. I thank you.
thank you, Honorable Minister. And I think it's a very big discussion. We do not have this time to take the whole discussion, but I think that the way that you have focused, it shows your commitment. And this brings hope to us, that until and unless, I believe, that the government, together with the NGOs, work together, will be doing, until and unless that we do it, we do sectoral approaches. And sectoral approaches is not required. What is required, one comprehensive approach for people with diabetes. As our Honorable Minister, Dr. John, have mentioned, that we need multi-sectoral approach. And this multi-sectoral approach, we must think of the civil society, we must think of the NGO sectors, we must think of the international bodies like WHO, also the industries. We all are partners in this. With this, I think that we proceed, and this time that I will have to continue to set the scene, and the topic of setting the scene is the global impact of diabetes and the barriers to diabetes care. So this will be, I will give a kind of short presentation, and honorable ministers, you may take your seat, please. So if you look at this, for example, global impact of diabetes, so you see that this is actually that what we have already been discussed. It is not one disease, as we have said, that it is a kind of micro and macrovascular complications that we say. You can think of the heart, you can say peripheral arterial disease, you can say the diabetic retinopathy, the cataracts, the glaucoma, diabetic foot, diabetic nephropathy, and peripheral neuropathy, stroke, so you name it. So it's not only one disease, it is affecting the productivity. And so if you think that, for example, that diabetes should not only be considered as a disease, it should be also considered as a factor for development, because it halts the development of a country, because it affects the the younger population. Next one, please. So this time that we have learned from this time of COVID, that this is the, one of the first publications that we made, along with me, that we see the people with diabetes, they have 300% the higher risk to die compared to a person that who is non-diabetic with infection. So diabetes is not only kind of non-communicable disease associated, it is also related to the infectious disease, as COVID has taught us that how vulnerable the people with diabetes are during this pandemic. Next one, please. Next one, please. So if you see this increasing of global impact of diabetes, you see that where we are, this is our atlas, the IDF Atlas, is showing that where we are, despite of all our knowledge, despite of all our involvement, where we are seeing that it is mounting. It is mounting as in 2021, we have 537 million people globally, which we are projected to 2030 to 643 million, and 2045 is 784 million. Is that something that we can live with? It is that where we are failing, we need to think concentratedly. Probably one of the things that we are saying, that we have sectoral approach. We are not talking to each other. We need comprehensive approach. We need to evolve, and we need to understand the limitations that each approach has. The next one, please. So if you see this, the increasing global impact of diabetes by 2045, you see where is the highest rise? You see this is Africa, 134%, where the resource is constrained. But for example, if you say that there is a Middle East, is 87%, Southeast Asia is 68%, and South Central and South America is 50% increase. In total, globally, there will be 46% increase. So this is what we are talking about. Next one, please. So if you see that 1 in 10 adults between 20 and 80 years has diabetes, that amounts to 537 million. Adults is undiagnosed, and we have to remember that half of these people remain undiagnosed, and they are the ticking bomb that is staying in our society. 1.2 million children and adolescents below 20 years have type 1 diabetes. 1 in 9 adults, 28 to 80 years, has impaired glucose tolerance. That means that, again, the 541 million we sometimes call prediabetes, and we say that glucose intolerance that I would say. People with diabetes live in low and middle income countries. 3 out of 4 people with diabetes live in the resource constrained societies. 3 out of 4. And 6.7 million deaths are attributable to diabetes. But still, must say that this is an underreporting of the deaths, because people generally don't die of diabetes, people die of diabetes-related complications. And when they die of diabetes-related complications, that in the death certificate it is written the complication, not the diabetes as a cause for the death. Next one, please. Barriers to ensure access to diabetes care. What I'm saying here, that what are the barriers? I'm trying to make kind of synopsis. Please accept my limited knowledge in this area. So we all need contribution. None of us know everything, but these are the things that we think that is important to draw attention to. The insufficient resources and ineffective system to ensure access to essential medicines and diagnostics. So you see that we have the resources. You see that if you go to those ministries, we know that nowadays, almost in each ministries, we have one section called NCDs, NCD section. It varies from 4 to 10 people working there. Just imagine a situation, country that where I originally come from is Bangladesh, we have 167 million people. We have 11 million people with diabetes. How these people will ensure the accessibility of insulin to all these people with diabetes? So it is understaffed, and also insufficient resources, as I said it, but also an ineffective system. Why I'm saying ineffective system, I will give an explanation later in the next slides. ineffective system to ensure uninterrupted supply of insulin and supplies to those who need them. 50% people with diabetes who needs insulin do not have access to it. And this is the fact of today. In sub-Saharan Africa, only 1 in 7 people living with diabetes have access to insulin. Almost no national survey policies to diagnose diabetes remains. Few countries have actually a policy to do a national survey. Therefore, 50% people with diabetes remain undiagnosed. About 35,000 young people with type 1 diabetes die undiagnosed each year. So this is the fact on the ground on which we are addressing the issue of accessibility of care. Next one, please. One of the things that you raised this question that you can see here, that you see that this is the cost of production of insulin, and this is the government procurement prices, and the patient prices, and in the private sector and in the public sector. The maximum price, the cost production, actually this was published only in 2021. It's not that old one. The maximum price is 3.42. The maximum price that is sold in the private sector is $50. If you look at the analogs, the maximum price that you can have is 17.35, or let's say $18. The maximum price that it is sold is $251. We need some consensus. The international body must come together. This is beyond the era of the national governments. This is the international era. The industries, the international bodies should come to have a kind of price tag that how much price could be. Of course, it's the national government's responsibility, but it is also the responsibility of the international bodies. Next one. If you look this system, why I said it ineffective system, you see this is one system that I have taken from Vietnam as an example. If you look this massive picture, that you can see that how do you ensure that these people coming to medicine, that all these things, that distributor and 7%, this is the responsibility of the national governments, because the national governments can break these barriers. We don't need all these layers. At the end, we are selling it at the final price is between 130 to 150% more than the price that comes here. But this also takes time, and the supply chain can be stopped at any places where there will be shortage of supply of insulin. And this is the national government. So I see that why the international bodies and national bodies work together. These are the clear examples that why national and international bodies should work together. Next one, please. So now, based on this scene, we should have a discussion panel. And in the discussions panel, this will be the responsibility. This will be the responsibility of our very good friend, Dr. Roglic Gojka. So you will please come, and you will be the moderator for this panel discussions, and you invite the panelists and introduce them. Thank you.
Thank you, Mr. President, ladies and gentlemen. Greetings to all of you at whatever time of day you're listening to or watching this session. My name is Gojka Roglic. I am a Croatian former diabetologist and epidemiologist, now happily retired after having survived working in the WHO diabetes program for more than 20 years. So I have made it to a pension. I still have diabetes very much in my heart, and WHO work in collaboration with IDF. So I was honored and happy to accept moderating this session, and also seeing many faces that I knew. I have collaborated with quite a few of you, and I'm happy to meet new people always. So it's an honor for me to moderate this session, and let me now invite the panelists to come to the podium. Professor David Beran from the University of Geneva. Dr. Bente Mikkelsen, my former boss in the NCD department, director of the NCD, the Non-Communicable Diseases Department in WHO. Professor Akhtar Hussain, please come back, Akhtar, and contribute to the panel discussion. And Mrs. Aida Ahmadpour, a consultant working for WHO, for specifically the Global Diabetes Compact. So we can start with the contributions of the panelists, and please keep your intervention to 3 minutes. We are encouraging people who are watching on Zoom to also submit questions, and there will be some, of course, opportunity for the audience to ask questions. Dr. Beran, could you please start? Thank you.
Thank you, Gojka. Thank you also to the International Diabetes Federation for this opportunity. I'm going to start off by being positive. I think these are exciting times to be working in diabetes. We've celebrated the centenary of the discovery and first use of insulin, which revolutionized type 1 diabetes and changed it from being a death sentence to a manageable chronic condition. In thinking, though, about these exciting times is also to think about how different organizations, different stakeholders played a role. And I think Professor Mintzberg from the University of McGill offers an interesting way to look at our success in diabetes. So he describes society as a three-legged stool. One leg is civil society, another leg is government, and the third leg is the private sector. And I think each of these legs have contributed to these exciting times. We've had the Diabetes Compact led by WHO. We've had a resolution on diabetes where member states played a role. We've had funders step up to the table, private foundations, governments, which have led to exciting research projects. We've had the private sector step up in different ways. And all of this has resulted in innovation. But I think we also need to celebrate those victories, but also have a dose of reality for people living with diabetes, as our three honorable ministers described the situations in their countries. Access to insulin still remains a challenge, and it's a failure of the global community that as we sit here today, that people are still dying from lack of access to this life-saving medicine that was discovered in 1921. We also fail in terms of delivering health care for people with type 1 diabetes, for people with type 2 diabetes, gestational diabetes, managing complications, and also addressing mental health issues that are so predominant. The social determinants of health that impact people with diabetes, but also are leading to people developing diabetes, whether it's access to nutrition, access to physical activity, or the wider society that we're creating. And how do we address these vulnerable populations that exist everywhere, not just in low and middle income countries, but even in a rich country as we're sitting here in Switzerland. And then the challenge, as was mentioned, in humanitarian settings. And that also, despite all this innovation in diabetes has come with increased costs to health systems, increased costs to individuals, and also increasing inequity. So I would argue we know what we need to do. We have guidance, we know what we need to do, but we are facing a complex challenge. And I think we shouldn't shy away from this complexity and try to oversimplify what we need to do to improve access to insulin, to stop the rising tide of type 2 diabetes. And that each of us, whether we represent a government, the private sector, civil society, or an academic institution, have our roles and responsibilities. So for the private sector, how can the private sector step up and also view the private sector in health not just as the pharma industry, but those others that are contributing to this? So how do we address big food? How do we collaborate with the private sector? How do we ensure that conflicts of interest are managed? As some of the panelists said, with governments, how do we involve other sectors? And also, how do we guarantee that health systems and governments have responsibilities to their populations, but also that high-income countries play a global role in their responsibility as global actors? And then finally, civil society, how do we guarantee that we hold the private sector, governments, WHO to account, but also foster collaboration with a view of improving the lives of people with diabetes globally? Thank you.
Thank you, David. Now, the next speaker, Dr. Bente Mikkelsen. So, Bente, you are the leader of the Global Diabetes Compact, and it is a major push towards improving things for people with diabetes and preventing diabetes in the first place. So what is the potential of the Global Diabetes Compact to radically change the situation?
Thank you very much, and thank you, Gojka. It's great to see you, and you will never retire. That's the point. Excellencies that we have, excellencies here in this event, I think that is also a proof of the importance. And thank you very much for your very, very insightful interventions, really deep understanding on what it means to make political commitments. And thank you very much, Akhtar, President, and also IDF for organizing this event during the World Health Assembly. You know, and we have to celebrate together that WHO exists to promote health, keep the world safe, and serve the vulnerables. And it is actually the 75th anniversary of WHO this year. And I want to say that, you know, I'm very proud of also Dr. Tedros. You listen to him. He has a deep insight in the current challenges for the world and the growing importance and growing, I would say, worry that we see during the last years and even the prospects of the coming years when it comes to diabetes. It proves that global leadership is there, and it's also extremely necessary. He said in his opening speech on Sunday that WHO had used most of the 75 first years on looking into communicable diseases. And he stated the fact that there is a paradigm shift, and now we have to look at the non-communicable diseases. So that's the starting point, and I believe that all of us in this room, we have a relationship with diabetes. Either we are ourselves affected, or we know somebody that is affected. And I think that has been the turning point, Gojka, when you're asking about the Global Diabetes Compact. I think the fact that we have been able to engage with the people with lived experience is really a game changer. This is something we saw during HIV, and I would say it was the turning point for HIV, which actually suffered from many of the same things that we see today for diabetes, namely lack of access to medicines and access to care. So I think without the people with lived experience, the civil society, we will never be able to make it. What we did to establish the Global Diabetes Compact came out of need. I think you said as well, you know, David, that we were asked to celebrate the 100 years of the discovery of insulin. But I think we very quickly realized that we celebrated the fact, but we couldn't celebrate because it was not available. Very, very in contrast to what Professor Banting said. He said this should be for free to the world. So I was very grateful on the day, 100 years after the discovery, that we had heads of states, that we had the government of Canada bringing us all together and kicking off the Global Diabetes Compact. So I think my first intervention would be that I think what we have achieved so far is building on IDF's very long-standing work, all the other partners in the room, but really made an opportunity for everybody to come together, to also steer this compact together through the forum that we have developed, to bring in the people with lived experience, also having an excellent technical expert group that guides us. And I would say already at this stage that we now have partners stepping us up, like WDF, like Helmsley Trust, but also the government of Denmark, also the government of Germany, also the European Commission, and now more and more member states are asking for support. So I think this is maybe the most important. as a starting point. Thank you.
Thank you, Bente. And what keeps coming up is we need innovative solutions or innovative approaches. We can't keep doing the same thing, expecting something different to happen. So, Professor Akhtar Hussain, IDF President, you are a sort of Norwegian-Bangladesh combination, and you have experience from innovative approaches in Bangladesh, in a low-income country, or maybe it's now a middle-income country by the World Bank classification, but definitely a setting that can really do with innovative approaches in using the community, for example, for improving care. So please tell us something about that.
I think that that we need to have some kind of innovative approach, as you said. And I think that I was also told to say that what an association can do in a poor countries setup, which I will address later. I think in Bangladesh Diabetes Association have, together we are a number of group of people that we have involved in 2 community-based programs, which could be very interesting for many of our colleagues. One, let's say that we have the so-called the Imam project. Imam is the religious leader in a congregation in Muslim faith, as you have the priests for the Christianities and so on. So the imams, what we are doing, we have now trained more than 70,000 imams in Bangladesh about diabetes care. Quite interestingly, those who are familiar with the Islamic law, they know that an imam is not supposed to be paid. Imam is not a kind of job. Imam is supposed to be a person that who leads the prayer is the imam for that. It's not a kind of Christianity that you have an employed priest. In Islam, imam is a person that who serves, lead the prayer. So what we said that according to your religion, you are not supposed to get paid. But we are teaching you how to do the testing of blood sugar. Very simple. We can teach you. We can ask you, we can teach them how to do the blood pressure. Just simple 2 things. The money they are collecting is very negligible. It's about in total it's about $2. No, sorry, $0.2. $0.2. And with this $0.2 is covering the cost for the test kits, and a certain amount goes to imam for his service. And then we have, that after the prayers, there is always a sermon. As, for example, you have in Christianity, the Muslims also have a sermon. And in the sermon, in the Islamic world, there is a very good advice in terms of diet. Prophet said that if you eat your full stomach, you will not go to heaven. You will have to understand those people who do not have enough to eat. So therefore, you will always remain a little hungry. So you cannot eat more than 3/4 of what your stomach wants. So we try to change what is in the Islamic faith to say to the people and you see that these people, they organize on Friday prayers. These imams, they organize in these 70,000 people have organized more than 10 million people. 10 million people gets the message in every weekend. So religion is a powerful tool if we can use it properly. So this is one thing that we are doing. Second thing, we are addressing the issue of gestational diabetes, and which is also supported by actually World Diabetes Foundation, WDF. What we do, we have created a kind of the so-called the pre-pregnancy clinic. The pre-pregnancy clinic, and then again, there is some kind of religious leaders that who actually perform the marriage. So these religious leaders were trained to talk about diabetes. So when these people, because in Bangladesh, in a society that Bangladesh, so there are very few people who are born outside the marriage. So the marriage is the starting point. So before they get pregnant, they were saying that these are the signs and symptoms of it. And if you agree, we pass this information to the pre-pregnancy clinic. So the pre-pregnancy clinic contact this couple before they get pregnant. So we are following them up and finding out any micronutrient deficiencies, any health issues, for example, hypertension, whatever, before they get pregnancies. And we have 200,000 pregnant women under our survey to see that whether this way we can actually stop the gestational diabetes. One thing we must understand, that if we cannot stop gestational diabetes, we will not be able to prevent diabetes. Because diabetes, when you are born, you are most likely you are already programmed. The so-called the fetal programming, as you all are familiar with. So we need to do something before they are being programmed. And so this would be I think this is the largest cohort in the whole world that would say that given 200,000 pregnant women versus 200,000 pregnancy as control. So this would give us some clue that whether we would be able to prevent. So these are the two innovative approaches we are doing for prevention of diabetes.
Thank you, Mr. President. And now, Ms. Aida Ahmadpour from the Global Diabetes Compact. You're working concretely on the Global Diabetes Compact itself, and if you can say a few words about the work that you're focusing on.
Yeah, absolutely. Hello, everyone. Can you hear me okay? Yep. All right. Well, thank you for including me in this discussion. And before I get started on my spiel here, I want to know how many people in this room actually live with diabetes, if you don't mind raising your hands. So, right, we have 1, 2, 3, 4, 5, 6, about 10 people. And for those of you joining virtually, perhaps you can indicate in the chat. So for those of you that raised your hands, how many of you are actually in a position in which you have influenced a particular policy or program that directly affects your life? How many hands? 3 hands, 4 hands. So about half of that. Well, I am not only a member of the WHO Global Diabetes Compact, but I'm also a person living with type 1 diabetes since childhood. And I would like to begin today by not sharing my story, but rather sharing a few words from other people living with diabetes who recently participated in a WHO focus group for the global diabetes community. So bear with me, please. Quote, "Being unemployed, I cannot afford treatment. I have to choose between the use of insulin or test strips," end quote. Quote, "I have received different treatment because of the color of my skin. I have seen situations where one child was educated about continuous glucose monitors, while a child of color diagnosed at the same time was not. People make assumptions that communities of color cannot afford certain devices," end quote. Quote, "I have the right to eat healthy food, but sometimes I have to choose between food and medicine," end quote. I could go on and on all day, but this is just a very, very small sample of a wide range of experiences and perspectives that WHO continues to learn from. And through our engagements with people living with diabetes, we understand that challenges with access to medicines, quality care remains the primary concern. We know this already. But what we are also learning, and what we continue to do by connecting with the community, is that these barriers are not only predicated on financial constraints or a lack of availability of needed supplies. Yes, that is the issue. But the correlating experiences of racism, stigma, discrimination, food insecurity, mental health, education access, availability, proximity to primary care facilities, non-individualized treatment also contribute to these barriers for people living with all forms of diabetes. So what's also sad, what we're learning through the community, is that these challenges seem to know no geographic border. There is no boundary to this. It appears to be consistent among people living in low, middle, and high-income countries. It is also consistent for people living with all forms of diabetes. And so the question I hope that we can all answer today in some form is that what are we going to do about this, right? Because the status quo of lack of access of essential medicine is unacceptable. This is a matter of human rights. This is a matter of life and death. And it is a dire problem that I know very well that WHO is committed to helping member states solve. So I'll stop there for now. Thank you.
Thank you very much, Ida. It is quite illuminating, and given that people on the forum are people who have access to internet and have a computer, one can very well imagine easily how dire things are for those who do not even have computer access to participate in such a forum. Must be much, much worse. And they are the majority of people with diabetes. A few questions for the panelists. Now, David, maybe you to start with. Insulin is always a very interesting topic, and it involves a lot of passion and interest, and it's a life-saving medicine. So what is so complicated about access to insulin? What is so complex? After all, people have been producing insulin in a kitchen with a sort of relatively primitive chemistry knowledge and primitive devices, almost no labs. So what is the problem?
Well, thanks for your question, Gojka. It's true. I mean, any well-equipped lab in a university can produce insulin. The issue is, can you produce it to scale? I mean, we're talking about millions of people needing insulin every day, and also at a constant quality. And I think what we need to remember is that insulin just doesn't appear by magic in someone's hand, and it has to go through this relatively complex process. So first, we need research and development and innovation to discover insulin, to discover new insulins, to discover new devices. The challenge there is that innovation has always come at a higher cost to health systems, to individuals. As Professor Hussain showed in the graph, you can see that analog insulin is much higher priced than human insulin. Insulin in pen devices is much higher priced than in vials. Then this innovation, this insulin needs to be produced. And here we see a concentration of the insulin market in 3 large multinationals controlling over 90%. So is that also a barrier? Insulin is complex to manufacture. I think that we need to remember that. But coming back to some of the points that the honorable ministers made around accessibility, markets, and the lessons from COVID, do we globally want our insulin to be supplied by a few companies? The next step is then this needs to be registered. So we need regulatory authorities to register these insulins, guarantee that they're safe. And again, insulin being a biological, it's a slightly more complex. I think to WHO's credit, the inclusion of insulin on pre-qualification is a success. We have 2 insulins now pre-qualified. Unfortunately, these are still from large manufacturers. So can we expand this? Then the next step is these insulins need to be selected, included on essential medicines list, included in national guidelines. We need to determine their price. These need to be included in reimbursement. And here we see, again, what do we see as essential for diabetes versus what do we all want? I mean, clearly as people involved in diabetes, we want what's best for people with diabetes, but we need a dose of reality in terms of what is affordable for health systems, what is affordable for individuals. Then this insulin, once it's included, then it needs to be bought and supplied within a health system. And as Professor Hussain showed, there's markups within the system. We've seen the weaknesses of global supply systems, national supply systems during COVID. So how do we address that? And then only after that stage are we entering the health system with all the barriers and complexities of accessing a health system if we live in rural settings within low and middle income countries. Do we have access to a health professional who can prescribe, who can manage diabetes? Do we have access to pharmacies that can dispense insulin? Is the insulin available in the public sector? If it's for free, or do I need to go to the private sector and pay a much higher price? And then also, ultimately, we need to remember the final step is the use of insulin by an individual in a given context. And for those of you who were here early, you saw the video and the challenges that the young boy faced in terms of access to food, access to education, self-monitoring, and all those levels create this complex environment that unfortunately leads to the situation that we're all too familiar with, that insulin, despite having been discovered in 1921, first used in 1922 in Canada, still remains a challenge for many globally.
Thank you, David. Ida, perhaps you have some ideas about how exactly would be best to have people with diabetes contribute to policies related to diabetes care. Is there some sort of standardized approach that you would imagine?
I think the most important thing is that people living with diabetes need to be placed in positions of power, in positions of leadership, in decision-making roles within your organizations, whether you are WHO, the International Diabetes Federation, Ministries of Health. It is very, very important to include people in that capacity. It's also important to include people living with all forms of diabetes. This is not just a type 1 diabetes issue, and we've discussed this already. But in order to create more participation opportunities, you have to have a level playing field. There has to be an equal power balance so that those ultimate decisions have been really richly and very honestly informed by that experience. It's also important to include the perspectives of people who are currently in humanitarian emergencies in those decision-making roles. When those crises are happening, it's very important to include them. Finally, you need to compensate people for their time. People with lived experience, this is evidence, this is expertise. So if you are going to create those opportunities, please pay them, right? This should be standard practice within all organizations rather than calling on people in a volunteer capacity. WHO has recently launched a framework on the meaningful engagement of people living with all non-communicable diseases, neurological conditions, mental health conditions. This is a guiding principle. Include them, create those opportunities, put them in positions of power, and pay them. It's a start.
Thank you, Ida. I will not go into eking out a definition of meaningful engagement, but I guess we have a similar idea over what that would be. Dr. Mikkelsen, Bente, please, any very concrete steps on how stakeholders can be united over all issues related to diabetes?
So first of all, I'm very proud that we have Ida. We also have James Elliott that is supporting the Global Diabetes Compact. So I think we have started to walk the talk. So, and it's really rewarding. And I think you had very, touching and disturbing stories to share, Ida. But I would also like to say that many of the things happening now in the interaction with the people with lived experience is also new innovative solutions. So I think, first of all, they give us the reality check, but they also support us in finding solutions, just to round up that one. So I think there is no easy way, but I think we have done this now quite systematically. We have built on the experience from Santa Diabet, from IDF, from WDF, from all of you that have been working in this field for so many years. But I think we all agree that what we have achieved now the last 2-3 years is to really raise the visibility for diabetes. It was about to sort of be a little bit a forgotten disease, and people thought that we had the solution because we had insulin. And I think so many of us have said that that is only one piece of what is needed. So I think the way we did it with establishing the Global Diabetes Compact, but more importantly on the let's say, the power side was that we had a resolution from the member states. So we were asked by the 196 member states of WHO to come up with recommendations. And the next thing we got was also an agreement of the targets. And I think we cannot underestimate how it will sort of spell out when we have targets. When we have a target that says that 100% of all type 1 diabetes patients should have access to insulin, and we are going to check in on this, we will create a monitoring framework that will check the accountability, and not only to blame and shame, but also to have this as an entry point for technical support to countries to help them to actually achieve all these 5 targets that is set out. And I think that is very important. Also, that the member states agreed to include access to diabetes treatment and care in humanitarian crisis was a big breakthrough. And of course, you know as much as I do that it is actually the lack of insulin that has led to that many of the people in refugee camps lost their limbs. It's not actually bombs or any of this. And this has been known by people working in emergency for many, many years. And now I think we have the opportunity to take this very serious. The other thing is that through the 6 work stream and the recommendations that we have set out, we try to cover all the different dimensions. So we have already touched on the very important fact of the need of access to medicines and especially insulin. And in that work stream, we have, as David has talked about already, actually got the first 2 insulins pre-qualified. I think it was very, very challenging, disturbing, that we had set up a methodology to pre-qualify already in 2019, and it was just now after our very strong push that we got pre-qualification. The other thing that happened, and maybe some of you was in that event, we also now see that companies are doing tech transfer and they want to do local production. And we heard our Excellency here talk about the need for local production in Africa, but I don't think it's only in Africa. I think we need to diversify the local production of insulin, and that is actually happening now. We also have development agencies like the Swiss Development Agency that want to look into pooled procurement and really want to see how we can mobilize the UN community. And another way that we do that is also to work on comorbidities. You probably already know that the big international funding institutions still are more engaged or almost fully engaged in malaria, TB, and HIV, and they haven't been able to include yet cancer, diabetes, and so on. But we are now working very closely with our colleagues on tuberculosis, and we have flagged the importance of the link to diabetes, between diabetes and tuberculosis, which you know is an increased risk. And we see member states are utilizing this opportunity to include now also proposals for diabetes in their proposals to the Global Fund. And we stand ready to help because it's so important to show the demand. We know it's there, but unless we are able to show it to those who are the ability to fund, we cannot actually achieve very much. So I'm extremely proud. It's 2.5 years of very hard work, and thank you very much to the colleagues in AFRO who now has taken the opportunity to train the people that are actually developing these proposals for the Global Fund and the World Bank in the evidence that is behind these kind of comorbidities. Another thing that is important is the research, and you were mentioning gestational diabetes. There are several gaps that needs to be closed. And we base our technical guidance and normative work on research and evidence, and we need to have researchers to continue to engage in all dimensions of diabetes prevention and treatment, but also access to care. So this is something we really are trying to utilize our technical expert group to help us to define and also to mobilize network of universities in all parts of the world that can help us to demonstrate and identify what is the most important research question. I want to mention two more things. You can stay very rest assured and very sort of calm on one thing. What has happened after the resolutions is that we have full engagement from the regional offices at WHO. And that is important because it cannot happen in Geneva. It cannot either happen in the regional offices in Brussels and Copenhagen, but they have the opportunity to really work with the countries. So we have seen now that we have mobilized the 3 levels of WHO to be joining in this fight, I would call it. And just now this year, we have the second high-level meeting on WHA. And many of the questions that you have raised already, and was also a very strong illustration from what Ida is saying, is that there is a need not to just occasionally prioritize diabetes. This has to be a core in any universal health coverage. There has to be a financial protection when we have these diseases. And unfortunately, they will not go away. We will probably be much better in controlling them, but they will exist. So on the second high-level meeting of WHA, there is an opportunity to also focus on this. And this is for the member states and other decision makers. So WHA is building on primary health care. And I think to be able, it doesn't matter, to be able to continue to improve the care, we also need to see how can we include the diabetes care into the primary health care and even to community-based care. So these are illustrations. So there is no simple answer, Gojka, you know that. We need to work on all dimensions, but this is what I really are very happy about, that we have defined probably all dimensions. I will end with the last thing, which was a very strong message from Ida. And what we have done in the space of meaningful engagement is also to focus on language, because we could see that even the language is stigmatizing. I had for the first and so far last time in my 10 years in WHO, I needed to take down a tweet that was tweeted from corporate level at WHO. And this was because we had people living with diabetes calling us and saying, this is stigmatizing. You are blaming us for being obese and for having diabetes. So we don't accept this. And we took it down. And I think that was the spur to really look into, and it's difficult. We will do failures. I am not a perfect person. You are not perfect persons. We will do mistakes, but we can be corrected if we are open-minded. So I didn't put much time now on health promotion and prevention and the obesity questions, but I can reassure you that this is one of the work streams, and we are working with our colleagues in nutrition, in all the risk factor areas as well. So thank you very much for the opportunity to lay this out. Thank you.
Thank you, Bente. I have just one quick question for Professor Hussain. Bangladesh actually has quite a tradition of innovative approaches to diabetes. When you mentioned the community approach. When I started my diabetology days long ago, the system of payment, of covering of costs of diabetes care, rich people were made to pay more for health care of poor people, to put it simply. So there is a tradition of innovation. IDF has appointed the Prime Minister of Bangladesh as the global diabetes ambassador. And what were the main reasons? maybe you went to school with him, but I guess there must be some broader motivation for this step.
Thank you very much, because I think that as first of all, Bente Mikkelsen, that I would like to congratulate you for your, I know that your commitment towards this Diabetes Compact. And this is really a kind of game change situation people are looking. And the second question is that either that you're concerned that to make the people with diabetes more powerful. I think we have enough powerful people with diabetes. Problem is that many people with diabetes who are not powerful. And the question is that, for example, my friend, His Excellency, has diabetes, but he's not powerless. But I'm sure that in Zimbabwe, in some rural areas, an uneducated farmer also have diabetes. How to make them powerful so that their voice is being heard. That will be the biggest challenge for us, and that we require. Going back to the prime ministers, yes, when I took, we all have our journey, and when I was elected as president, I was thinking that what would be my thinking, that we have long blamed the government for not doing anything. We have long blamed the government, the policies being developed by the WHO or IDF is not implemented at the grassroots level. What has happened? Nothing happened. They are business as usual. So what I thought that whether we can encourage the people, we can try to see hard that which government is doing something. It's not that no government cares. We can try to see that whether some government is doing something and whether we can recognize them. And by recognizing them, I think that will give a kind of greater incentive to work for it, or instead of blaming them, because then they will not listen to it. Because politicians in general, they have their own agenda. That not necessarily diabetes is on their agenda. So how to make? So we, at that time I talked to my president at the time, Andrew Bolton, and he thought that it's a very innovative thinking, so he said that, okay, go ahead with it. So we set up a commission, and then we tried to look hard that which government, we had many proposals, and then we looked at it. But we found not because that I went to the school with the Prime Minister of Bangladesh, and although we, as a student, now I can say that main reason that I left Bangladesh is because of politics. I would have been jailed, or I would have been not alive today. If I were in Bangladesh, I had to run away. So we belong to the same party, that was true. But that is not the reason that we had a committee that we looked around. Actually, what she has done is quite remarkable, that in a poor country like Bangladesh, that we are talking about a country with 170 million people. She has committed to give free insulin to all type 1 diabetes people. This is something which should be encouraged. What she has done, she has also developed some 500 NCD corners throughout the country, where you can get a free diagnosis, and also some treatment free. But of course, you know that it's not like Norway, where I live, where Bente's country, and I often say that she's a white Norwegian, I'm a black Norwegian, but we have the same country. So it's not the kind of that you can choose the drugs. There are some drugs that is available in these 500 corners. In addition to this, she has also created 50,000 that is called community clinics in every village. They work as a kind of referral system. This has actually revolutionized that. If you knew, the UN has actually recognized the Bangladesh Prime Minister for achieving the Millennium Development Goals. Because one of the few countries where the maternal mortality reached the target of maternal mortality, the child mortality. Our maternal mortality and child mortality rate is now lower than that of India. So we have made some, if you look at this, women education rate is higher now in Bangladesh. Literacy rate is higher in Bangladesh than compared to our neighboring countries. So we have, so the committee, the committee came up with a kind of, and we must say that this is also one factor that we have also considered. She's a woman, and who has a kind of highly motivation for For example, she believes in secular state, that in a time of all kinds of extreme nationalist countries that we live in. So these factors also played a role, and the committee anonymously actually nominated her, and that was the reason that she was given this award. But she is a symbol. The idea is to see that whether by rewarding the governments, we can have more engagement from the government side. So this was the whole idea. And what we see today, that I see that actually I see that there is an election this year, Bente, in Bangladesh, and then she is using this, that she is the global ambassador for diabetes. And in that way, that actually she is making a commitment to people. I see that she's saying that if you have any problem with insulin, come and contact my office. And this has an impact on the whole healthcare system. And this is by, when you use us, you also become dependent on us. So this is, in short, this is why we thought, and of course this is an experiment, whether it will work or not, we do not know. This is the first time that we have introduced this system, and we hope that in 2025, when we'll have the next General Assembly, we'll be able to find another worthy global ambassador for diabetes after her.
Thank you, Akhtar. I will now open the audience, the questions for, I see a few hands up. The first hand I saw is the lady in the second row. Yes, yourself, Phil. She would need a microphone. Please, if you can please identify yourself,
Yeah.
and say who the question is for.
Right. So my name's Samantha Bolton, and my question, well, I guess it's for WHO and the diabetes, for everyone. I almost dropped dead actually in Switzerland from type 1 because I was over 50, and normally you get fat, and I got thin. Anyway, but I also worked for years for MSF on the Access to Medicines campaign, and what's clear is the success of that campaign on HIV has pushed everyone towards treatment. And you know, it was really encouraging to hear what you were saying about Bangladesh, because, I mean, my question is linked around the activists, right? We know that American activists are very well organized, and it's all about treatment. And also many of the activist groups are working, well, you know, it's in the interest of the pharmaceutical companies also to push maximum use of drugs as opposed to lifestyle change. So when I was at the university hospital here in the Urgence, I asked the chef de diabétologie, how much insulin does the worst patient in Geneva use? And they have a lot of immigrants, a lot of poor people here as well. And she said, or he said rather, around 200 units a day is the worst at the university hospital, and that the average person is on 25 to 35 units a day. I then was following the insulin train in the US, where they're lobbying to go to Canada for insulin. And the doctors are saying, my average patient needs 200 to 300 units a day. Because in the US, doctors do not tell patients, don't drink Coke, don't eat this, because it's all about the patient's right to eat food. And because of this very active group, the push at the international level, just as you said, you are working on nutrition, but I mean, I think it was only David who mentioned the food companies and the crap that we have in our food. And I'm just wondering, where are you at in terms of talking about lifestyle and training doctors? Because in the US now, doctors cannot tell a patient anything. And since Michelle Obama's gone, no one's talking about obesity and lifestyle. And it's much easier for everyone, pharmaceutical companies, activists, to follow the US route, just drug them up, drug them up, drug them up.
Who would like to answer the question?
So if I can just, I think we have different angles on this, but first of all, I couldn't agree more, and it's not only for diabetes. So what we do at WHO is we have an NCD Global Action Plan, and linked to that is cost-effective interventions. And if you look at that, I just came from presenting them. If you look at them, the most cost-effective interventions we have is actually regulatory interventions. that increase taxes on things that are unhealthy, decrease access, and so on. So the whole NCD agenda where the diabetes sits is very much on prevention. So we say usually that 2/3 of the impact comes from intervention. But you are fully right. We have problems, we have challenges. I just had the chance to discuss with several deans of medical schools and also public health schools on how much they train doctors, nurses, midwives on prevention and on public health intervention. And they were all in agreement, far too little. So I think you're also right when you say that this is a push from industry, it's a commercial determinants of health, and it's much easier to give a pill than increase taxes on unhealthy food, sugar-sweetened beverage. But that's why tomorrow I'm very proud that the World Health Assembly is hopefully agreeing to the next update of the Appendix 3, as it's called, all the interventions, so at least we have something to offer. There is no excuse, but a lot more needs to be done when it comes to prevention, especially when it's training of healthcare workers, but also to strengthen, I would say, the self-confidence of people that are suffering from obesity. We see seldom that these are really holding their own governments accountable for not being able to access healthy food, for example. So not an easy answer, but thank you very much for raising this very, very important question.
I think that I would like to also add this, what you have pointed out is a very real problem. It's a very real issue. The reason is, for example, one of the examples that I said that, for example, I'm very happy to WHO that you do not recognize the term as prediabetes. I have always difficulties to accept it, that, for example, in any other disease, you do not find these terms, like, for example, pre-cardiac patient. You do not hear this. You only hear for prediabetes. And the very reason that you have a diagnosis, the very moment you say a diagnosis, you give medications. Your moral responsibility, because you have an ethical responsibility to give drugs unless somebody is diagnosed. So the very word that prediabetes that we should be talking about, rather some kind of glucose intolerance or certain things, but not this term giving a kind of diagnosis. I have seen that the doctors mostly are reluctant to talk about, for example, prevention, because they think that prevention is not their area, is the area of the social scientists, nurses, someone, but it's not our job is to. So the whole concept of medication, the doctor's training, needs to say that, I always say that if you cannot talk about lifestyle, you cannot treat a patient with diabetes. But this is what I say, but this is not. But you can also see that, for example, but you see that America is one of the, even it's a rich country. If you see this, for example, people who are uncared with diabetes, particularly type 1, the highest number of people are actually in the United States, between 18 to 25 years of age. So this is a known fact that if you see the prices of insulin in the whole world is the highest in the United States compared to any other countries in the world. And this is because the regulatory mechanism and the strength of the industries in that because of powerful lobbying at every stages. But this is not only happening this is also happening very much in the poor countries, even in my country. I see that doctors have gold cards, have their yellow cards, and have their blue cards. That means that how many times you can go international conferences with your family by the companies. So I think the companies will also have a kind of, because if you see that, for example, in Norway, for example, in a developed country, we have strong regulations, what we can do with the companies and what we cannot do. But in the poorer countries, we do not have such strong regulatory bodies. So this is a real issue. This is a real problem. I have to admit, I come from a poor country originally, and we have to see that this is a real problem in treating patients with diabetes. You can also see that, for example, all these new drugs that you were talking about, which is very much expensive, that we can see that many of the doctors don't understand the statistics. You see there is a kind of HbA1c fall off between about 17% or for example 20% lower, that the risk of, for example, coming down. But what it actually means to an individual patient, if you have a kind of HbA1c of 9, is that you have taken down to 0.2%. That means you have 8.8%. So your complication risk for the complication is equal. But that people don't understand, not even some of the doctors. So we have a number of problems, and we also need to train doctors in order to people with diabetes, not only their diabetologist or endocrinologist. Thank you.
But perhaps Ida would like to chip in. I mean, after all, you're American and an activist as well, so you certainly have something to say.
Yes, I'm American. I have, experienced this firsthand. I have direct experience with this. I think that I want to get back to the information we're learning from the community rather than my own perspective. And what was also quite telling in this recent focus group we had was that the ties to the interactions at the primary care level, at the point of diagnosis, and the language that is used, the advice that's given, perhaps sometimes the lack of guidance, the lack of recommendations, this was quite consistent in these experiences. So I tend to think from the ground up rather than top-down approaches. And I think at that level, at that primary care level, what can be done to change that experience? What can be done so that that language about nutrition, about engaging in that individualized way, what do you have access to in your life? What is happening in your life? What is available to you? What is not available to you? Those are questions that are not necessarily being asked at that primary care level in the States. Perhaps in some contexts it is. I can say a lot at a personal level, but I will refrain just because I'm part of WHO. But yeah, I'll just leave it there.
Okay, thank you, Ida. Questions? The Honorable Minister, Excellency, please.
I just wanted to have a short comment in your respect, Professor Hussain. You are aware that in Pakistan what is going on, the first knowledge. In the survey I just reported that, and around 8 million people are in need of insulin. So as we all talk about that there should be a public-private partnership, and the civil society or the other organization may come in forward and to help us. So these 8 million people who need insulin, but we are currently in short of developing our own insulin. So the IDF is requested that to look at that issue into your agenda, one of the agenda, because the sooner the best that we are able to make our own insulin. So these 8 million people at least will be having easy access, which is the basic right of a diabetes patient. That is my request to IDF.
Thank you, Excellency. The lady in the second row here, you're closest to my eyes, so I sort of get to pick you.
Thank you. I'm Dr. Charlotte Désé, and I'm a director of a small French NGO. And I would like to talk about prevention and innovation, just to give you an innovative way to think as well. We are a small consortium between an NGO, 2 startups, and an R&D laboratory. And the R&D laboratory, a French one, it created a new design, a new screening test, non-invasive test for their insulin resistance. So you know that insulin resistance is appearing 10 to 15 years before the onset of the diseases, of the cardiometabolic diseases, not only the type 2 diabetes, but also the cardiovascular diseases, the NASH and all that things. So we have now a new tool for showing to the people that they have a major risk factor for developing these cardiometabolic diseases, and this is reversible. So with changing the habits, they can reverse their insulin resistance, and they can avoid to have these cardiometabolic diseases like diabetes and all that thing. So that I would like to say is it's really important to look ahead. It's important to treat the people who are diabetes now, but it's also important to reduce the incidence of the future ones. And there are innovative attitudes, so yeah.
Thank you very much. Maybe one last question, the lady behind you, just right behind you.
Yeah, thank you. So my name is Layla. I actually come from Bosnia and Herzegovina, which is a small country in Europe. And as a person with lived experience, I really have to say some things because I feel it's always the elephant in the room and it's very hard to address. And I know, Ida, you're in a very uncomfortable situation. And you do have to watch out how you're going to say certain things because we are all aware of underlying issues that exist. For example, we in Bosnia have managed to get our health insurance to cover CGMs. And no one wants to register their products in our country because they don't find it a profitable, attractive market. And no one wants to talk about that. And when talking about like insulin, okay, the price, what does it mean? It means that our health insurance covers insulin, but if the price is reduced, there are so many things we can do with that money. For example, fund CGMs. So I think it's the bigger perspective and the impact that it has. And again, it's mostly the patients driving those things. And we did get our health insurance to have those legislations, but we don't have the support from the HCPs. We don't have the support from the manufacturers. And as you said, there's a big issue of, you know, like I personally went to one doctor, got one insulin, went to another doctor, got another insulin, and then every time I would go to checkup, I would get switched between insulins because they were both represented by different companies. And I think those are issues that are not being addressed, and it's very hard to talk about them. And I think, you know, commenting all these things, it's very hard to be a patient because you really want to find the middle point of, you know, talking to the healthcare professional and being a facilitator in the room and make everyone happy, and it's really hard. And I really think that it's a great initiative to have people with lived experience, and many of us are working in the field, and it's so amazing to see that is being supported because you really do need to take into consideration the lived experience. What is the lived experience? It's everything I mentioned. It's seeing the corruption, the underlying issues that we may recognize in our societies that need to impact those big decisions being made. So, yeah. Thank you.
Thank you very much. And final comment or question from the Honorable Minister of, Deputy Minister of Health of Zimbabwe.
Thank you. Can I have this bottle, please? The blue one. Yeah. In life, people get what they want. The multinationals, in terms of food and everything, you are all even afraid to say this because you think they will sue you next week. But who is suffering? It's the diabetes, people living with diabetes. People get worse. If you look, even the food companies, manufacturers, what they want you is to know that this is aquapar, whatever, okay? But the contents or whatever might be detrimental, say this is a drink or food, will be in very small print. Why? It's because they know you will not pay attention to small print, you pay attention to the big letters. Are we together? So, we need not only be afraid, because you know they are multinationals, they have loads of monies to sue you. But we must start lobbying that. In terms of food labeling, for the diabetic, yes, he has the right to eat and all those rights are there. But you also have the right to know what's bad for you. Reading these things might be difficult in understanding them. I'm sure, Prof Akhtar, you will agree with me that when you're crossing a road, red means stop, green means go, yellow means something in between. If we did the same thing with drinks and food, it will help a lot of people. Even this pre-diabetes and all that is something that we'll be able to tackle much more easily if food labeling and drink labeling was changed to say, this food stuff means red, this is green, this is in between. People must understand what they are eating. People must understand what's good for them. Yes, the big companies have the right to have money, but we also have a right to life, a healthy life, because most people just eat out of ignorance. People may not understand what they are taking into their bodies, may not be good. So we need an easier way of knowing these things. Yes, they will be very angry because they make their millions out of your ignorance, out of our ignorance as diabetics. So we need to change that attitude and say, red is bad for us. And if you look at all companies, they just make big letters for what they want you to take. What happens to you, it's none of their business. All they want is to make sure their bank accounts are strong and fat. Thank you.
Thank you, Excellency. And I think we don't have time for any more questions. Unfortunately, there were also a few questions, well, quite a few questions on Zoom, but I think we have to wrap up this session. Hypoglycemia is slowly kicking in, so it's time to eat. A lot has been discussed, a lot has been thrown out on the table. There is very good reason for optimism. Not everything is rosy, unfortunately, but I think there is reason for optimism. So I would like to thank the panel for the contributions, and I would like to invite Professor Akhtar Hussain to close the session.
Thank you. Thank you, Dr. Gojka. Thank you, all the panelists. Thank you, all those who participated and being so patient. And I think what gives hope is your engagement, not the panelists, the so-called experts that we are sitting as. We are not a part of the solution. You are a part of the solution. And that brings hope to see so much engagement. Wherever I go, when I talk to the people, I see so many engagement of the people. As I said that I come from a poor country, I have seen parents, when we gave free insulin to those people, they sold it in the market. And when they are caught, they were said that if I do not take insulin, I will die after 2 years because of complications. If I do not eat, I will die after 1 week. What do you want me to do? So this is the choice that people have to make. But the worst case that I have seen, when a patient's daughter died who was type 1, he was happy. He was happy because now he will have the money to buy food for the rest of the family. Do you think that a poor man loves his daughter less than any of us? And this is the reality on the ground. So with these words, I will say thank you for your engagement, thank you for your time, and this really brings hope to all of us. One thing I would request at the end, I tell to everyone that whenever we have any event that we organize, we have a list of sponsors. We never name among the sponsors, we never say people with diabetes. We talk about the companies that we have sponsored, where the money comes to this company. The money comes from the people with diabetes, and they are giving a fraction of to you. You recognize this company, fine, you do that, but do not forget to recognize people with diabetes no matter where you do. And in IDF, I have told very strongly, any event that you organize will have to recognize the people with diabetes. Thank you.